4, but on average, if we sampled 1,000 people, it would average out to 98.6. So if you have to have an intact neurological system to be able to control your temperature. Pyrexia means fever. Heat generation, like pyromaniac, generation of heat. Insensible perspiration or loss, that's the fluid that we can't really measure, right? We sweat, we use a little bit of fluid from our skin all the time. Even probably as cold as it is in here, some of y'all are probably using a little bit of fluid from somewhere. And a recurrent fever is just a fever that keeps coming back. Okay, so we're going to talk about the inflammatory process, and anything that you see, any word that you see that has itis on the end, I think that might have been a suffix from last week. It means that it's inflamed. Typically when we see itis, we think that means infection, and for the most part it does. We kind of use them synonymously, but literally it just means that something's inflamed. So like if you have tonsillitis, you've got a big swollen set of tonsils. If you have appendicitis, it's your appendix. Anything that's got itis means that it's inflamed. So we have this inflammatory process. It's a protective mechanism for us. We're going to talk it through so that you'll be able to understand things that happen, why they do happen. But basically, the inflammatory process seeks out to try and neutralize anything that gets into your body that shouldn't be there. And I'm going to refer to that as a foreign invader, just because we don't want to say a laundry list every time we're talking about something getting into your body. That could be the serum from a snake bite. It could be a sliver of wood. It could be you eat all the contaminated food, and it's bacteria that gets into your gut. It's anything that gets into your body that shouldn't be there. So the inflammatory process sets out to neutralize that and to wall it off and to dilute it. And so in the process of doing all those things, you get those 5 cardinal signs that you see listed there: redness, swelling, heat, pain, and loss of function. We're going to talk about why all those occur. Inflammation, like a lot of the other processes that we've talked about, so I click this on somewhere where y'all can hear me. Can you hear me any better? No? Well, I'm running out of hands, so I'll stand over here. So acute inflammation is inflammation that happens, it lasts a short period of time, and there's a trigger. You can identify what caused it. So let's say you do get a mosquito bite. Well, you're going to have that pain, redness, swelling, loss of function, all those 5 cardinal signs, but you know what caused it. It was the mosquito bite, and we know it's going to last a few days, and then it's going to go away. So that's what an acute inflammatory process is. We do have chronic inflammatory processes, and it's different from acute in that we don't really know when it started. Like I've noticed my shoulders getting sore. I don't remember falling on it or overextending it or anything happening to it, but it's been getting sore and swollen for a few days, and I don't really know why. And now it's a month and it's still swollen, and I don't know why. So in a chronic process, it's not quite as pinpoint an area. It's more diffuse. You probably don't know what caused it, and it kind of hangs around a long time. Typically, you also have more scarring with something that's chronic, right? You get a little paper cut that heals in 2 or 3 days, you don't typically get a scar from that. But if you get a great big old wound that takes 2 months to heal, you're going to have a scar from that. So whenever there's something foreign that enters your body that shouldn't be there, the first thing that's going to happen is that you're going to have increased vascular permeability and vascular dilation. So what that means is that the blood vessels serving the area are going to dilate out and get big. And this is vascular permeability. So if you think of this as a vein and a capillary bed, the other side of the capillary bed and an artery, the blood's coming through, and my fingers are pretty tight here. And so not a lot's gonna go through there, some would, right? If I scooped my hand down in a bucket of water, I could probably get a little bit to drink right before it all leaked out of my fingers. When you increase that capillary permeability, this is what happens. Now, if you see me trying to scoop up water out of a bucket, you think I'm gonna keep any of it in there? No. So, that's what causes the swelling when you have an inflammatory process. That capillary space opens up, it's called increased capillary permeability. And it allows the things that are in your bloodstream, antibiotics, antibodies, white blood cells, platelets, anything that needs to get out to help control the damage that this foreign invader has caused, it leaks out through that capillary space. So we have these big blood vessels that have dilated more, and the bigger the blood vessel is, the more blood's going to get to the area. So again, your body's trying to get those white blood cells and antibodies and all that kind of stuff out there, and the capillary space opens up for them to get out. That where it says recruitment and immigration of white blood cells, that's what's happening after the capillary space opens up, the white blood cells start moving out, and then they're going to clean up the mess. They're going to, do whatever it is that the cell type is supposed to do to clean up the mess. So like an antibody would attack the antigen, a white blood cell would start gobbling away at the bacteria that got under your skin or into your skin. So right before that capillary dilation and capillary leak happens, you get just a brief moment of vasoconstriction. Some of you may have seen this before, like you got cut by something really sharp. Again, a paper cut's a really good example. When you first look, you can see the edges all of a sudden they tighten up and it gets real light in color, and then it starts to bleed. So that's thought to be protective, but it doesn't really last long enough to protect us for very long. And then after that, we have that business that we just talked about with the capillary space opening up and the increased volume. Ooh, sorry, exhaled right into the microphone. Some of the factors that play a role in that increased vascular permeability are listed here for you. Histamine and prostaglandins, those are huge. Histamine is released from mast cells whenever there's a foreign invader in your body, and it causes that vasodilation and the capillary permeability. Does that ring a bell with y'all? So, you know, if you maybe have an allergy to bee stings, or I don't know, something that makes you itch, you might take a Benadryl before you use that shampoo that makes you itch, or you've gotten a big bug bite and you take the Benadryl because you think it's going to make the swelling less. Well, it does, because it's an antihistamine. It works against the histamine that's causing this whole process to be. With that vasodilation and increased capillary permeability, we already said you get increased blood volume, and volume is hydrostatic pressure. We're going to talk a lot about hydrostatic pressure next week when we talk about fluids. But if you increase the pressure in a pipe, what's the fluid trying to do that's in a pipe? Trying to get out, right? Think about those little, the balloons that people blow up and make animals out of, New Orleans or wherever, like clowns, they'll make little dogs and cats and princess hats and that kind of thing out of those long, skinny balloons. Well, with that long, skinny balloon, if take a 10 cc syringe and you fill it with water, it's probably not going to stretch it very much. And if you were to pop it, it would kind of start leaking out. But if you took a garden hose and filled it up to that tiny little balloons now this big, it's going to just burst, right? It's going to spray its fluids out more quickly. So that's what's happening. You increase that, the blood volume, the hydrostatic pressure in your vascular space. And so those things lead to the redness and swelling and pain. Some of the cells that are involved, things that you need to be familiar with. Neutrophils are a type of a white blood cell. Remember we learned last week that what's a low neutrophil count?
Less than 500.
Yeah, less than 500 is critically low. Critically low, not critically ill. You would probably be critically ill if your white blood cell counts that low. So those are the first blood cells that get out to the site of a foreign invader. So if you were to trip and scrape your knee and some dirt got in there, neutrophils would start going out there to try and clean that mess up. So if you have anything that has particularly bacterial that's gotten into your body, you would expect that you would have a big increase in your neutrophil count. And that's called the left shift that you see up there. If you remember, we said white blood cells live, 6 to 10 hours. So, in the normal white blood cell count is 4 to 11,000. So, if a person has a bacterial infection, their white blood cell count is probably going to be 17, 18, and upwards. It's important to know they're the first ones there, and if it's elevated, it means that there's a bacterial invasion somehow in your body. And the word there where you see it says bands, those are just immature neutrophils. So if you see a report or you hear somebody talking about a left shift or bandemia, band, E-M-I-A, bandemia, those all indicate that you have a bacterial infection. When you have a respiratory tract infection, or your kids do, and they have a sore throat and a runny nose, and you go in and you see the healthcare provider, and they will prick the heel or the finger, what they're looking for is to see what your white blood cell count is. If your white blood cell count is elevated, they're going to put you on antibiotics. If your white blood cell count's not elevated, they're going to come back in the room and say, this must be viral, so, Johnny's just going to have to tough it out, and it'll go away. Eosinophils and basophils, those are also substances that cause vasodilation. They are not as big a player as the histamine is, and they are released whenever you have a foreign invader that comes into your body. Eosinophils, particularly when you have an allergic reaction. And then monocytes are another kind of white blood cell. They work the same way as neutrophils, but there's not nearly as many of them. In your blood, on a white blood cell count, the normal number is much lower, something like 3 to 5. It's very, very low. And so they do the same thing that a neutrophil does, except that they don't die off in a few hours. They live for days or weeks, and they convert to another cell type called macrophages. That's also a telltale sign that you have a chronic type of infection, a chronic type of inflammation going on versus something that's short term. So maybe, if you have a wound that doesn't heal and, you're trying to decide, is it bacterial or is it malignant, is it cancer? A macrophage is showing up there would indicate that it's a long-term inflammatory process, so it's a good piece of information to have. And then lymphocytes are also a type of a white blood cell, and they will also destroy pathogens, and those numbers will be elevated if you have a viral infection. So, we kind of already said this, but the inflammatory process gets started. And the thing about the inflammatory process, y'all, is it happens the same. It doesn't matter where it is. So it's really easy to see if you think about, getting a dirty fish hook stuck in your hand, or you get that mosquito bite. You see what happens, right? It starts to swell. It gets red. It'll start oozing fluid if there's not any skin intact, that kind of thing. Well, the same thing's happening to your bladder if you have a urinary tract infection, or it's happening in your lungs if you have pneumonia. So you have that increased blood flow, that leaking of fluid, regardless of where it happens. So it's really a non-specific process that happens the same way, regardless of the cause. So anyway, you have these white blood cells that get activated, and you also have platelets that get activated. And platelets will stick to the line, to try to go and stick wherever the damage is, because they're trying to control bleeding. And then the white blood cells get out there and try to start cleaning up the mess. So those cells will move out close to the wall of the blood vessel. They'll go through that increased capillary space, and they'll get out there and they'll eat the foreign invader. Okay, so maybe it's something like you might see on the test. If the patient has a white blood cell count of 23,000 cells in a microliter, what do you think is wrong? What is the first kind of cell to get out to clean up a bacterial infection? Neutrophils. If it's a viral infection, your white blood cell count's not going to be elevated. An inflammatory response, it's not very specific, and you might could say it's true, but the most correct thing there is a bacterial infection. We talked about histamine a little bit. There's some other chemical mediators that play a role. Bradykinin is one. Bradykinin cause pain. So when you do get a cut or you get a bug bite or, whatever happens, the pain is caused because of the release of bradykinin as part of that inflammatory process. Prostaglandins, you see down there, also cause pain. And bradykinin and prostaglandins also add to that capillary leak and the vasodilation, but again, histamine is the strongest player in that capillary leak. Cytokines are, just know that they have, they send chemical messages around in the bloodstream. And then the thing to know about C-reactive protein is that it is elevated if you have an inflammatory process. So when you see patients that are having a C-reactive protein lab test, they're trying to figure out if they have an infectious process or an inflammatory process going on. So it just all you need to think of it, all you need to know about that is that it is a blood test that reflects whether or not there's any inflammation going on in your body or not.
You say that again?
C-reactive protein, a lot of times it'll be abbreviated CRP. It is just it's a lab test. What I want you to know about it is that it's a lab test that's used to determine whether there's an inflammatory process going on in a person's body. Back to that, like we talked a little bit before about maybe somebody has, you need to distinguish between a person maybe having a cancer or having a chronic inflammatory condition. That C-reactive protein is a good test for that because if it's elevated, it's probably an inflammatory process. If it's normal, it's not an inflammatory process, so then you have to, do your diagnostic path in another direction. So if you have an inflammatory process, you're going to have some fluid that comes from that inflammatory process. And these are the different types, and I'm going to tell you what they all mean, and you'll need to remember these forever. So what will happen is once you are out and working, you're going to start using, medical terms instead of layman terms. So serous drainage, y'all know what serum is. Y'all know what serum looks like. Serum is that part of your blood that kind of looks like urine. It's clear and it's yellow. If you've ever seen blood that is settled to the bottom of the tube, it's the yellowish part up top. We talked about that with, I think, fibrin last week. So, a blister, for example, the fluid that's going to be in a blister is going to be very serous. It's clear, it's light yellow, it will congeal some. So if you have, a person who has a wound and you take the gauze off, and that's what you see is that light yellow, kind of looks like urine on a gauze, that you would describe that as being serous drainage. Sanguineous means blood. I think sanguineous must be a Latin word for red, I'm not sure. But if it has sang in it, then it has blood in it. And then serous sanguineous then would be either what looks like diluted blood, or it might be clear yellow with little streaks of blood in it. So if you've ever had surgery, or you had a baby, you had your teeth pulled, you probably noticed that when you come out from the procedure, what's on the gauze is very bloody. And then, a day or two later, it's starting to look kind of light pink, or it might even just be mostly clear with just a little bit of red scattered in it. And then it turns to clear, and then it should go away. That would be the normal progression of how the exudates should change in a person that has an inflammatory process going on. And I think we mentioned this last time about fibrin. Fibrin is the stuff in that yellow serous drainage that makes it congeal. Did we talk about that last week or no? Okay. So fibrin is the stuff in your blood that provides structure for healing to happen on. And so as your body, when you have an injury, fibrin is released immediately, and it starts congealing, and it is a setup so that the cells that have to do the repair work have a place to stick. So again, back to that burn injury that you have, that little blister that you have. If the blister stayed intact and you waited a couple days to peel the skin off, which you should, it would kind of look like jello, clear jello on the finger. And then purulent or suppurative is the word for pus. We don't ever write pus in a chart. So it's, or either purulent or suppurative drainage, but that's what it is. And what is it in pus that makes it what it is? There's a lot of white blood cells, that's why it's opaque looking, and it's gonna have cell fragments from the, whatever it is that the white blood cells are trying to destroy, whether it's bacteria or a piece of suture, anything like that. And then you can also have wounds or ulcers. See, I'm not gonna pop over to this and watch it in class, but it's a visual, it's a little video, I think it's YouTube probably, and it shows you how you have the injury and how you get the vasodilation and that capillary leak and everything moving out and cleaning up and healing's getting ready to start. So y'all can watch that. So if a person has an inflammatory process, they can have local signs and symptoms, which are the things we just talked about, the redness, pain, swelling, heat, and loss of function. That's what's gonna happen at the site. Even if it's the liver or it's the lung, those same things are gonna happen. But then we have manifestations that show up throughout the rest of our body that indicate that there's an inflammatory process going on. Those are called systemic. So some of the things that happen when you have an inflammatory process that is not directly at the site where the injury is you might have a fever, right? You might have an elevated white blood cell count. You might have that elevated C-reactive protein that we talked about. There's one on here that says ESR, the one at the bottom, and that's erythrocyte sedimentation rate. So that's the rate at which red blood cells fall through that tube of blood. So back to talking about fibrin, when you pull blood off of a person, and you set the tube up in a rack, and you time how long it takes it to fall, there's there's an average time, there's a normal time range. Remember how we said that fibrin starts to appear in that serous fluid to provide structure? Well, now these red blood cells have to work, instead of just going boop, they have to go fall around these strands of fibrin, so it takes it much longer for those red blood cells to fall down in that tube. And that's what the SED rate is, the erythrocyte sedimentation rate. It's also called a SED rate or sediment rate. So if you have an elevated C-reactive protein or you have an elevated SED rate, it's gonna be an indication that there's an inflammatory process going on. And then you can imagine you're probably weak and tired, you don't feel good. You all have had some kind of cold before. Maybe some of y'all have got COVID when COVID was first, in 2020 when COVID was so bad. Maybe you've gotten it recently, I don't know, but you know how you feel right before you get sick, you're just lethargic and you're tired, you might be a little headachy, you probably don't feel like eating, you probably don't feel like doing much. Those are all systemic signs that there's an inflammatory process that's going on. Swollen lymph nodes. We talked last week about if you have a non-tender lymph node that's swollen, it's a clue that there may be a lymphoma going on. But if they're tender and swollen, then the chances are you've got an inflammatory process. For chronic inflammation to occur, there can be several things that play a role. Some pathogens just are chronic, like tuberculosis. Once you get tuberculosis in you, it is going to cause a chronic inflammatory response. It's going to take 6 months to a year to clear that particular pathogen out. So there are some pathogens that are more prone than others to cause chronic inflammation. Environmental exposure, that makes sense, right? If you, so we went to the beach and, we spent days in the water with salt on our faces and the sun beaming down, so all of our lips stayed a little bit, chapped and peeling and that kind of stuff because we were chronically exposing ourselves to something in the environment that was making that happen. Maybe you live in a place where you don't have good sanitation. Maybe your water is contaminated. Or, things are not going to heal if there's chronic exposure to an infective agent. And then clearly if anybody has an autoimmune disorder, which we'll talk a little bit about this later, but if your immune system doesn't work well, it's going to make you more likely to have an inflammatory condition that's going to last a long, long time. we mentioned before that kind of a telltale sign that there's something chronic going on is that there's gonna be macrophages. And these macrophages end up leading to the formation of this granulation tissue that you see there, or granulomas. So again, if you have a surgical cut, you cut your hand with a knife, it's gonna heal up very quickly, and you're not gonna have all this raw meat that happens. But if you have a deep injury or a big injury, you're gonna have this formation of granulation tissue, and the goal there is for that tissue to fill up the void to where the injury is. You can see here where that's, done over and above. So for healing to occur, we're gonna need those fibroblasts that we said are gonna be released in the serum, and they are going to go wherever it is they need to go to set up the structure for the cells to adhere to so that healing can take place. Then we're gonna have endothelial cells, which are skin cells, that are gonna have to reproduce to try and close that area up. And then we have myofibroblasts, and those myofibroblasts cause the wound to contract in. So, y'all probably can't see this on my finger, there's a little mark there that's about the size of a pencil lead. So a few weeks back, I have a sewing machine, a little heavy duty sewing machine, and I stuck a needle from this side to that side. And so I had to go and have it cut out. Well, I had a wound that was this big from where they cut that out, but can you see that teeny tiny little, it's been healing in from the side. They put some stitches in it, but it was still open, and so it's been contracting in, getting smaller and smaller and smaller. And you all probably did that falling off your scooter or your bicycle growing up as a kid, and you might have skinned your knee this big, and that scab just kept getting smaller and smaller and smaller. That were the myofibroblasts that are pulling that in. You do need to be familiar with what kind of cells heal, or that are constantly regenerating, which ones never regenerate, and which ones just regenerate on demand. Luckily, that's gonna match up pretty well to what you learned about which kind of cells get cancer the most often. So, those cells that are rapidly reproducing are gonna heal the most quickly. And that's pretty much your epithelial cells, your bone marrow, your mucous membranes. Then, cells that only regenerate when they need to are like your liver. Your liver is probably the best example of that. Your renal tubules will heal a little bit. Some of your endocrine glands will regrow, but they're not going to unless there is a need for that to happen. So if you're in an automobile accident, you have a big laceration of your liver, and they end up having to cut out half of your liver to keep you from bleeding to death, that will grow back. It's like a starfish arm. You break it, or a crab claw. If you take those off those animals, those parts will grow back. And then things that are poorly regenerate or don't regenerate at all are mostly muscles and nerves. So if you have damage to a nerve or to muscle, that tissue's not gonna grow back. That's the reason if you have a spinal cord injury, if your spinal cord gets cut in half, it can't ever grow back together. When you have a heart attack, it's a muscle, and part of that muscle dies in your heart, is never growing back again. So we really kind of already said this. Fibroblasts are the beginning of that collagen development, and then the wounds contract in, they close, and you get a scar. An important thing to know about a scar is, and it's probably really fresh or really clear for you to see when you have a scar on your arm or your leg, somewhere on your skin, and scars don't function like the parent tissue. They're just like glue. They just hold things together. So like if you had a big burn injury, for example, and maybe your whole arm is burned, that arm's not gonna sweat ever again. It's not gonna work like the skin does, right? It's just gonna cover. If you have a heart attack and you've got scar tissue on your heart, which you have to have if you have a heart attack, like there's not gonna be any electrical conduction across that scar, and that scar is not gonna contract in. So it just is, it's a Band-Aid. It holds the tissues back together. when we talk about healing, we talk about three different kinds. The first one's primary, and we've mentioned this several times today already. It's that paper cut, that surgical incision, where the layers of the skin line back up perfectly, and it just heals, and that heals in just a couple of days. You know, maybe a week at most. It took this about a week to heal up, but they got pretty deep in there. Secondary wound or secondary healing means that granulation tissue, remember I showed you that finger that had that blob of what looked like hamburger meat on it? Granulation has to fill in the wound, and then it will contract in from the sides. So if I had, a wound this big on my thigh, and it was deep, what would happen is it'd take a month or two, a couple months for it to heal up. That granulation tissue is gonna fill up from the bottom, and then the myofibroblasts are gonna make that contract in and close. And then the final kind is tertiary, and tertiary is kind of a combination of primary and secondary. So in tertiary healing, the tissues are allowed to stay open for a long period of time. Again, if I have an area that's this big, they may allow it to fill in so there's not a big deficit there, but then they're gonna have to go back and put a skin graft over it. It's real common that tertiary healing is used when patients have some kind of abdominal injury, a gunshot wound, maybe their appendix ruptured and it was terribly infected. They'll leave your abdomen open just with a surgical dressing on it to allow the inflammatory process to happen, so that all that swelling can happen, the infection can get gone, and then they'll go back and close it. So it's kind of a delayed primary. Now this is a list of things that can cause healing to be slowed down. So patients that have any of these conditions, it's gonna take them a longer time for their wounds to heal. So malnutrition, that makes pretty good sense, right? If you don't have the vitamins and the protein you need, you're not gonna grow any new tissue, it's not gonna heal. Oxygen delivery. So if there is not oxygen to tissues, it's not gonna heal. So who might have poor oxygen delivery? People who have pulmonary problems, people who smoke, maybe you have anemia. I couldn't hear exactly what was said on the wrong side of the room, but maybe you have vascular disease. You see lots of people that have wounds on their feet because their blood vessels don't deliver blood like they should to their legs. So anything that would cut down on the blood flow or the oxygen to the tissue. If there's anything wrong with your inflammatory response, a wound that is infected will not heal. So it's very common to see patients who will come to seek out healthcare because they'll say, I've had this wound on my foot now for a month, and it almost closes all the way up, and then it'll open back up. So if there is infection, the wound is not gonna heal, period, ever. If you have infection in the bone, there'll be a track from the bone to the outside world. If there's a foreign body left in there, so there's a splinter, there's piece of metal, piece of lead, that's gonna delay healing. My husband has a piece of lead in his elbow that a little girl in the neighborhood stabbed him in the arm with a pencil lead when he was a kid. And so it's healed over, but you can see that little black piece of lead in his elbow. It healed eventually, but I'm sure as a kid it took it a long time. Dehiscence and evisceration. So dehiscence is that this is a wound, and the wound comes open. That's what dehiscence is. Okay? And evisceration is what's behind the wound comes out. So if I have and this happens mostly in your belly. So if I've got a surgical scar, it doesn't have to be a surgical scar, but maybe what probably is going to be a surgical scar. Maybe I had a gunshot wound. Maybe I had surgery. Maybe I had a cesarean section. My little niece, she dehisced her cesarean section, her cut for her cesarean. So it pops open, and if I eviscerate, what's behind there is going to come out. So because that happens on your belly a lot, your intestines can come out. Hers luckily was below her peritoneal cavity, so it just opened up and pus came out. Dehiscence, evisceration. And that's gonna happen mostly if there's an infection. Because again, remember, if there's infection, the wound is not gonna heal. We've already talked about circulation. Obesity, there's not, if you have a lot of fat below the surface of your skin, there's not gonna be as much blood flow to the skin or to the areas that need to heal, and so it's gonna delay healing. And then the older you get, the more difficult it is to heal as well. So complications of keloids is that hypertrophic scar formation. Typically, the darker your skin is, the more likely you are to have a keloid. People with light skin do get keloids, but it does happen more often than people who have dark skins. Do y'all know what a contracture is? A contracture is when there's an injury over a joint, and as it heals and that tissue tightens up, it pulls the joint together. So if I have an injury in my antecubital fossa there, if I didn't wear a splint and didn't exercise, it might make my arm draw up like this. And so then your arm gets frozen like that because of the tight scar tissue. That's what contractures are. We've talked about dehiscence and evisceration already. Stricture formation. Stricture formation is a band of scar tissue forms around a pipe. So maybe you have consumed a lot of alcohol in your day, and it's irritated your esophagus, so you can form bands of scar tissue around your esophagus. And remember, scars don't function like normal tissue, so typically what happens with a stricture is that it's a really tight, hard band, and eventually you're going to end up with problems of flow through the pipe. So mostly those strictures are going to happen around blood vessels, or they're going to happen with something in your GI tract. A fistula, we didn't talk about this yet, about Crohn's disease, but a fistula is an opening between two body parts that shouldn't be opened. So it's kind of common for females, if they get a sexually transmitted infection, to develop a fistula from their vagina to their rectum. That's common. There's an opening between the two. Or maybe they got an infection post having a baby. Common that it happens there. Individuals who have abdominal infections or who have some different abdominal diseases will end up with maybe two pieces of the bowel sticking together, or even the bowel coming open to the surface. So it's an opening between two places in your body that shouldn't already be open. And then adhesions is a type of scar that sticks tissues together. So again, that's most prevalent in your belly. So if you've ever had any kind of belly surgery, you did have an appendectomy, or you've had some kind of gallbladder taken out or something like that. An adhesion is a scar that will stick two organs together or two pieces of tissue together. So a stricture is a scar that goes around a pipe. An adhesion sticks things together. Women who have endometriosis a lot of times will have adhesions where a piece of bowel is stuck to their uterus by an adhesion. Okay, y'all, so if you see a blood report and the person has macrophages in it, what do you think it means? It's C. Y'all all agree it's C? Mm-hmm. Why isn't it D? I mean, it is directly related to prolonged wound healing. Not the inflammatory response in the problem, it's the healing. That's the problem. So we're going to talk a little bit about how we control our temperature. First thing we have is a vascular response. What happens to your blood vessels when you're really cold? They constrict. That's why your fingers turn blue. Right? If you go outside and you get really hot, what happens? They dilate. That's why your skin turns red. So if a person is cold, they're going to probably have blue fingers, and they're going to be their blood vessels are going to be tight.
What does your skin do when you're cold to try and warm you up? It does the same thing, it's gonna constrict. How do you know a person's got constricted skin? They have goosebumps. Y'all know what goosebumps are? The skin tightens up and you get those little bumps. And the reason that it's important to know these things is so that when you go in and to look at a person, you have an idea, oh, maybe I need to check their temperature or not, you know. What position do you get in if you're cold? You move, right, because you're trying to warm up. That's that shivering business. Makes your temperature go up. Are y'all excited? We're gonna have some, like today, the high today's only in the low 80s, and we're gonna get some 60s in the next couple of days. Epinephrine and thyroid hormone. If you have a release of epinephrine or a release of thyroid hormone, it's gonna make your temperature go up. When you talk about a fever, have y'all talked about these stages of illness already in skills yet? No, okay. So prodromal, when a person has some kind of disease that's going to give them a fever, prodromal is when you're starting to feel bad, but you don't have a fever yet. So you can tell if something's not right, I'm probably fixing to get sick. That word malaise, M-A-L-I-A-S-E, just means you just kind of don't feel good. You're tired and achy maybe, and maybe have a headache. Maybe your eyes feel a little bit dry. Those are the things that happen before you have a fever. And then you experience a chill, and so when you're having that chill, what happens is that is the point in time where your temperature starts to elevate. Because remember we said when you're cold, you start shaking and your body processes speed up to try and warm you up. So you're not losing your fever when you have a chill, you're building your fever. And then when you flush, that means that your thermostat got as high as it's going to get for this particular fever episode. That thermoregulatory center in your brain says, okay, that's enough fever, it's time for this thing to break. And so you flush, which means that you're going to vasodilate. And that vasodilation allows for more blood to get to the surface of your body so that the environment can help cool off your body. And defervescence means your temperature's coming down. So you're going to have that flush and your fever's going to come down. If you take a Tylenol or an Advil, it's going to make this process go faster, right? Once your fever gets up, you're going to flush and defervesce more quickly. If not, if you don't take it, you're going to sweat it out. It's going to be up to that thermoregulatory, that thermostat in your brain that turns your fever off. And then fever in the elderly, there's a few things to remember about folks who are older. Number one, they may not have a fever. Right? As you get older, pretty much everything in your body just works not as effectively, not as quickly, not as responsibly. So you may not have a fever. You might not have an elevated white blood cell count either, or if you do, it might not be elevated very high. So it's really important that you look at what else might be going on with your patient. Super common, you're gonna, once you go to the hospital, you start working in the hospital, to know that when old people have urinary tract infections, that they typically don't have a fever, but they get changes in their mental status. And a change in your mental status is a big, big clue that a person has an infection, especially older people. So you're going to, again, be asking, an older person questions that might hint to you that they have an infection going on, because they may not have any fever, they may not have any pain in the area. So things like, is your urine getting cloudy, or have you vomited lately? Do you have any wounds, any bug bites, any wounds that might be draining? So you want to get really involved with what the signs and symptoms of an infection could be to help determine whether or not they have a fever. And then also, if in people who are older, they may not be as agile to get a temperature. We're using more and more like thermal scans. I quit. But if patients are using a thermometer that they put in their mouth,
You know, a lot of older people might have dentures that could change that. Maybe they have COPD or some chronic disease that makes it more difficult for them to keep their mouth closed tightly on the thermometer. So there can be those kinds of errors in measurement. Older folks don't have good vision, so they might be reading the number wrong and that kind of thing as well. So we have to be a little more careful when we're looking at older folks and we're worried about them having an infection. Y'all feel good about inflammation? What that process is, that capillary leak and all of that? Okay, so take just a quick little 5-minute break and then we're gonna swap gears, I think, to immunology. So a nice little list of words here again to start out with. Now, what is the antigen? The bad thing. It's the thing that's causing the problem. The antibody is the thing that attacks it. So see that word gamma globulin over there? Gamma globulin is another word for antibody. And so is immunoglobulin, which doesn't happen to be on this list of terms, but antibodies, gamma globulin, and immunoglobulin, that all means the same thing. And they're just used interchangeably in healthcare. In healthcare, you know, you honestly don't hear people saying, oh, well, we'll give them antibodies. It's more like they'll get some gamma globulin, or we'll give them some immunoglobulin, but just know that those all mean the same thing. Antibody, gamma globulin, and immunoglobulin. Those are all, 3 of those are the same. They all mean antibodies. Y'all know what tolerance means? Y'all know what it means to have built up a tolerance to something? Okay. And y'all know what a pandemic is now. Seroconversion means that point in time when you can do a blood test on a person and whatever you're testing for shows up. And typically what you're getting on that blood test is an antibody. So it's that point in time when a virus, or mostly viruses, become measurable in your bloodstream, or the antibody to the antibody to a virus. And then myalgia just means muscle aches and pains. Pyrogenic means it causes fever, right? Pyrexia means fever. So pyrogenic, something that causes a fever. And then autoimmunity means your body's trying to destroy itself, or part of it. Type 1 diabetes is caused by an autoimmune issue. Your body starts to destroy your own pancreas. So when we talk about the immune system, there's lots and lots of layers and lots of parts. The first is your skin and your mucous membranes, and as long as your skin is intact and your mucous membranes are intact, you've got a physical barrier. There's chemicals on your skin, you've got hair on your skin, there are lots of things there on your hair that help keep things from getting on or in you. Like when you think about the hair in your nose, it's there to try and help things from getting up into your airway. The wax in your ears, the same thing, it's there to help keep pathogens from getting down into your ear. So those are examples of the chemicals and the physical barriers that are there. We also have good bacteria and bad bacteria. I'm sure y'all are all very familiar with that. What resides on your skin normally should stay there, and it should help fight off or prevent pathogens from being able to make their way into your body. And then we have the mononuclear phagocyte system, and those are just a group of cells, mostly monocytes and macrophages, and then some dendritic cells. And their job is to present antigens to antibodies, and also to directly destroy that foreign invader. And then the lymphoid system, that's your spleen, your lymph nodes, your thymus gland. And then we talked a lot last week about your bone marrow making all of the cells that are in your bloodstream. So all of those white blood cells that you need to have, that you need to make, come from your stem cells, and all the antibodies you need to make come from your stem cells. Your bone marrow makes T cells and B cells.
B cells grow up to be an antibody. That's all a B cell is. So when we were talking last week about some cancers that were B cell precursors, those were precursors to antibodies. Now, a T cell can grow up to be any other cell in your blood. Y'all know about the spleen. It gets rid of debris and dead cells. So if you have an inflammatory condition going on, your spleen is probably going to get a little bit enlarged because it's got more trash to process. Your thymus gland is a gland in your chest, and in your bone marrow, from those T cells or B cells, those stem cells, the stem cells that stay in your bone marrow to mature become B cells, and the ones that move out to your thymus are T cells. It's pretty simple. And then lymph nodes really are filters. They're there to trap any foreign invaders and any trash, any cellular debris that needs to be removed from the bloodstream. This is just a nice little picture. I probably am not going to ask you where they are, but just so that you have an idea of where they are. Some of these cells we've already talked a little bit about, so that's good, right? Because it'll be a repeat and there'll be less content for you to have to learn. But neutrophils, remember we said that's going to be the first cell to get to the site of a bacterial infection. So that elevated neutrophil count is going to clue you in that there's an infection. And those neutrophils, their job is to consume, to eat, to phagocytize the foreign invader, just straight up get rid of it. Then eosinophils, remember we mentioned that they're very strongly released in allergic reactions. They also are active in parasitic infections. And then basophils and mast cells, again, allergic reactions. And then you're going to see more basophils if there's a chronic inflammatory process going on. Monocytes we've already talked about, they become macrophages. And then macrophages still act like a neutrophil or a monocyte in that they destroy foreign invaders. But the other big thing is that they present the antigen to the T cell. So the T cells really are going to be the directors of the immune response. And so if a T cell doesn't realize that there's some measles that's gotten into your body, no antibodies to measles are going to be made. So somewhere, somehow, somebody's got to get the antigen to the T cell so that the T cell can tell the rest of the immune system what to do, and that's the role of the macrophages. Dendritic cells play a smaller role in that presentation of antigens and suppressing viral replication, but we don't worry so much about that just yet. Lymphocytes, we have natural killer cells, we have T cells and B cells. So we kind of already talked about what these are, except for those natural killer cells. Those natural killer cells are part of your innate immunity. Everybody has natural killer cells that are just pre-programmed to destroy abnormal cells. We talked last week a little bit about, we all have cells that our DNA is getting messed up a little bit in, going on all day, every day, and that we have processes in our body that keep us from getting cancer, and this is part of what they are. Those natural killer cells will recognize an abnormal cell that doesn't belong in your body, not all abnormal cells, but some, and will just directly destroy those. They don't have to have had pre-exposure or anything like that, they just do it. It's part of being a human. This should look very familiar to you. It's that table from last week that shows you which cells are in the lymphoid system and which ones are in the myeloid system. So we're going to talk about these different kinds of immunity. And hopefully this is real familiar to y'all. Do y'all remember what innate immunity is? Innate immunity is that immunity that you have, you're born with it, and you just have it because you belong in the class of Homo sapiens. You don't have to have any previous exposure. It's more the physical things, the skin, the hair, the earwax, that protect you because you're human. Then passive immunity is immunity that's given to you somehow. You're not born with it, you don't develop it, somebody gives it to you. So there's really only a couple ways you can have it given to you. Babies are born with passive immunity from the mother. They have some antibodies that cross the blood placental barrier. And so you have some antibodies that your mom gave to you when you were born. Your mom can give it to you in breast milk. And then the only other way you can get it is if we give you an injection of gamma globulin or antibodies. So y'all were probably like in middle school when the pandemic started, right? Or maybe early high school. So you, so y'all would have been about what, 17, 16, 15, 16, 17.
That was 20.
20? You wear it well. You wear it well. So you may remember that some people, if they got really sick, they would go and get these infusions of antibodies. Do y'all remember that? And so what that is just someone who has had a given disease, donates their blood, they siphon off the antibodies, treat it hopefully to kill any other viruses that might be in the bloodstream, and then they can infuse it into a person. So if you received COVID antibodies because you were really sick with COVID, it helped fight off that, it helped your body fight off that COVID infection, but it doesn't do anything to make you immune to it down the road. It's a one-time deal, it helps you with that infection. So all of y'all will have had your hepatitis B series to be here and to be going to clinical. I think they're still giving you a little bit of grace time to get that finished up before next semester. But if anybody out here hasn't, or maybe you're a non-responder and you get stuck by a needle or you get some blood in your eye or some body fluid in your eye or mouth while you're at work, they're going to do a test to see if the person that you got that fluid from has hepatitis B. If they do, they're going to go ahead and give you some gamma globulin or immunoglobulin so that you don't get sick with the disease. But it's not going to protect you from having the disease. You're still going to have to get that vaccination series. Does that make sense? So it's given to you. It doesn't stay with you, and it's to deal with a one-time infection that is very specific only to that particular antibody, right? It wouldn't do me any good to have a hepatitis, to get hepatitis antibodies if I had COVID. And then there's active or adaptive, depending on which textbook you're reading, they call it different things. This is the one that you spent more time studying in your A and P classes. This is the one that you have to have exposure to the antigen, and post-exposure to the antigen, you develop antibodies that will then attack an antigen if it comes back into your body. It's going to activate the T cells, which are then going to provide direction for how many white blood cells to make and how many eosinophils to release and which antibodies to send out in your body to make that happen, to take care of and get rid of that infection. So if you remember, the first time a person is exposed to an antigen, they may have a reaction. They may not. Like maybe you're allergic to seafood. So the first time you had shrimp or crab or whatever seafood it is that you're allergic to, you might not have had anything happen. Maybe you had a little GI distress, didn't think much about it, but it's going to be on that second exposure where you have that big allergic reaction that we fear so much. Now you can have a reaction. For example, if you got COVID, or maybe you got the COVID vaccine and you had signs and symptoms similar to COVID, then that did demonstrate a reaction where you would have somewhat of the disease. Does that make sense? So you can either have no reaction at all the first time you're exposed, or you can have a disease, then obviously that would be a reaction. We're going to talk more about humoral and cell-mediated immunity in a little bit. So adaptive immunity, we kind of already said all these, didn't we? There's antigens, antibodies, T cells, and B cells, and then you have your macrophages. So we kind of talked about that already. Neutrophils we had just beaten up. They're the first to arrive. Their job is to eat bacteria. They're going to be high in number whenever you have an infection. major histocompatibility complexes we haven't talked about yet. Those are cells that are pre-programmed to attack something if it doesn't belong in your body. The biggest way to think, the biggest example, or I guess the clearest example of that is the macrophages that are on your red blood cells. So if I'm type A blood and I get some type B blood, those macrophages are going to cause a big hemolytic reaction just straight off the bat. So if you don't have those MHCs, those major histocompatibility complexes, on a cell that comes in, it gets attacked. Again, if I'm A, you're B, and there's the mismatch in that the major histocompatibility complexes, it's going to get attacked. If I get A blood and it's got MHC markers for A blood, then I'm not going to attack it. So these are super important when you start talking about having organ transplants and tissue transplants, and blood's a tissue. They have another name, HLAs, human leukocyte antigens as well. We've talked about monocytes. We really have kind of talked about all of these already, so we're going to go past that slide. We're going to talk about cell-mediated humoral immunity. So there's two different immune systems in that adaptive or active immunity. We already said this before too, I think, or maybe not, but your cell-mediated system is purely your T cells. And there are lots of different T cells, and the T cells direct the rest of the immune response. So the T cells are, controlling how many white blood cells I make, how many eosinophils I make, how many antibodies I make. We've talked a lot about T4 and T8. So a T4 cell has a cell differentiation marker number 4. So somebody in the lab somewhere identified all these T cells and saw these markers on them, and so they started labeling them T1, T2, T3, T4, T5. I don't even know how many T's there are. There's a bunch. So the T4 cells are the ones that really are the director of the response. So without a healthy number of healthy T4 cells, you're not going to have any ability to prevent your body from having an infection, to prevent your body from developing autoimmune diseases, to prevent your body from developing cancer. And then the T8 cells are the cell that has the CD, cell differentiation marker number 8. Those are cytotoxic T cells, and so they go directly and destroy foreign invaders. And then again, cytokines are sending chemical messages around that help direct the immune response. And then I think I've said a few times already that B cells all they'll ever grow up to be is an antibody. They're never going to be a macrophage or anything else. They're not going to be a T cell. They're going to become an antibody. So while you have some antibodies in your body. You all had to have a bunch of vaccines before you could come here. So you have your cells have the memory to create antibodies to hepatitis, or antibodies to varicella, or antibodies to the measles. So you don't have 100 gazillion antibodies right now sitting in your body for chickenpox. But if you are exposed to chickenpox, those T cells are going to say, hey, all you B cells, make me a bunch of chickenpox antibodies. Does that make sense? So they have the ability to develop very quickly because of the memory that they already have on how to do that. So there's a list here of antibodies, and you need to know what the roles are, what they do. So IgG is typically the second responder, and it's effective against toxins and bacteria mostly, some viruses. IgM is the first responder. So if a person has an elevated IgM, it means that they've got a recent infection going on. Then IgA is found in secretions. So people who have respiratory tract infections, and maybe urinary tract infections that involve bodily fluids would probably have an elevated IgA. IgD stimulates B cells, and IgE is important in allergic reactions. So I wouldn't worry so much about D, but I would try to know what the roles of these others are. E is easy to remember because eosinophils and IgE, they are both active in allergic reactions and parasitic activity. So E, think of allergies and parasites, or either eosinophils or for IgE. And that IG stands for immunoglobulin, immunoglobulin G. So again, immunoglobulin, gamma globulin, and antibody, they all mean the same thing. And honestly, we said this a few minutes ago, but that primary response is the first time you have an exposure to an antigen, and you may or may not have any kind of reaction. You may certainly develop the disease. And then it goes away, and maybe it's 10 years or 5 years before you're exposed to whatever it is again. And at that point, the preparation of the development of the antibodies that you need ramps up, and you have that big reaction. Yeah, hopefully the reaction is it keeps you from developing the problem. And then if it's an allergic type antibody, and it's an allergic type foreign invader, then you have the allergic response in its secondary exposure to the antigen. So here's a nice little question. You get COVID-19 immunoglobulin, so what do you get? If somebody gives you immunoglobulin, what kind of immunity are you getting? Passive. It's going to take care of that COVID infection. It's going to help. It might not take care of it, it's going to help, and then it's gone. So your immune system starts to develop while you're in utero. Babies are protected as long as they are in utero. Once they are born, they have a little bit of leftover immunity for about 6 weeks, and then they don't start getting vaccinations typically until they're about 3 months old. So there's that, I guess, period of fragility there, and it's usually like, people, physicians and whatnot, they recommend that you not take your babies to the Christmas party and to class to meet all your friends and that kind of thing. Your secondary lymph organs, your spleen, your lymph nodes, those are small when you're born. IgG is the only immunoglobulin that will cross the placenta. So if a baby's born and there's any reason to, something's not, the baby's lethargic, the baby's not gaining weight, the baby doesn't eat well, they may draw blood and check the antibodies to see if there's maybe an infection going on. Because if any other antibody is present, it means that there was probably an infection going on at the time of birth, and the baby probably has the same infection that the mother had. IgA is transferred in breast milk and colostrum. And then the older you get, again, the less effective your immune system is going to be. The older you get, the less effective all of your body systems are going to be. So we're going to switch gears just a little bit. We're going to talk about the different kinds of allergic reactions. There's 4. They're called hypersensitivity reactions. And so you need to, on these, know what is the cellular response and, what kind of examples of each of the hypersensitivity reactions. So what's going on and what causes those. So type 1 is the one that you hear so much about and one you fear so much, and it is it's an antibody-mediated response, and you have your IgE receptors get activated, and you have crazy amounts of histamine and basophils that get released. They cause that massive vasodilation and capillary leak. So it comes from the activation of IgE. You get big release of histamine from the mast cells and from the basophils get activated, and you just get an overwhelming vasodilation. So if you get a big vasodilation, what do you think happens to your blood pressure? It's going to go way down, right? So if you go back and you think about let's think about a balloon. So that water balloon that we filled up the little to make an animal out of, if we had that same amount of water and the balloon's not stretchy, what do you think the pressure is on the balloon? It's going to be kind of low, right? And the more and more volume that gets into the pipes, the higher it's going to get. But if you were to leave the amount of water constant in that balloon, and the balloon gets all stretched out, what's the pressure gonna do on the balloon? It's gonna go down, right? If it gets stretched and it's saggy and it's not tensile strength, it's gonna get less. Do you ever, like you have a garden hose and you have the hose turned on and so it's full of water? If the hose dilates out, the amount of pressure is going to be lower. I'm not giving y'all very good examples. So if the fluid that you have in a container, the bigger the container, the less the fluid's going to be, right? So if you have 10 ounces of water and you put it in a cup that's this big, there's going to be a lot of pressure on there. If you take 10 ounces of water and you put it in a cup this big, the pressure on the outside of the cup is going to be lower. So if you dilate the vessels, you're going to lower the pressure. So these folks end up with a drop in their blood pressure. They also can have smooth muscle contraction, and because your airways have smooth muscle wrapping around them, they get constriction of those vessels, and the muscles that then make the airways much smaller. So any pipe that you make smaller, it's going to be harder for stuff to get in and out. So if your airways are this big and you clamp them down to this big, you're just going to make it very hard for air to get in there, right? So you're going to make it hard for them to breathe, and you're going to make their blood pressure very low. You can't live very long like that. Now, that's the typical thing, you see it that gets played up on TV and that we worry so much about, but you can also have an IgE-related response that's not quite as severe, and you might just end up with hives and itching. But it's IgE-mediated, and you're going to have that vasodilation, you're going to have the bronchial constriction, and because it's an inflammatory process, you're going to have that capillary leak. So you think about those smaller airways that are now they're very small, and now you filled them up with fluid, it's going to make it even harder to breathe. So when a person has an allergic reaction, the best thing we can do is to try and stop the allergic reaction. And you'll learn a lot about that next semester. So then in type 2 hypersensitivity reactions, you have also have an antibody-mediated response, and you get activation of either your IgG or your IgM. It's not IgE, so it's a different antibody that causes it. These are you're going to get the same kind of result though, or you can at least get the same kind of result. This is the type of reaction that causes a blood transfusion incompatibility. And so, again, whenever there's a cell that's put into your body that doesn't have the MHC markers that it should, it's going to set off this type of hypersensitivity, this type 2 hypersensitivity reaction. So, any antigen that comes into your body that you don't already have, your body's going to attack. If you are type A blood, then that means on my red blood cells, I have an antigen, somebody's called A, so I have type A. So I automatically, without ever having had exposure to it before, make antibodies to type B. So if somebody puts some blood in me that's type B, I'm going to automatically destroy it. The RH factor is similar. You do have to have a first exposure to the RH factor first, though. With ABO, you don't have to, but the RH factor you do. So if you have RH factor, or if you're O positive or you're A positive, that means you have an RH factor antigen on your blood cell. So if I get RH positive blood, and I have RH positive blood, I don't make an antibody to it because I have it. If I'm O negative, if I've ever been exposed to RH positive blood, I start making an antibody to that RH factor. So that on the second time that the person receives some RH factor, they're going to attack that blood and they're going to kill those blood cells, and it's going to lyse those blood cells. That can be fatal to children. So think through about what kind of blood you can get, based on your blood type. So if I am O let's say I'm O negative. What antigens do I make? I make antigens to everything, right? Because I don't have A, I don't have B, and I don't have Rh factor. So if I'm O negative, I'm the hardest person to give blood to. Because you can't give me any blood that has A, B, or Rh factor on it. If I am, so O negative though is the universal donor because there are no antigens on it, right? So if I have O negative, if I give my O negative blood to somebody, there's nothing there for the person to form a response to, right? There's no antigen on it, it's O and it's negative. And so if I am, what would be the universal recipient? Who could get any kind of blood that wouldn't matter? AB, positive or negative? Positive, because it's got every antigen you can have on your blood, so you can't give me something that I'm allergic, that would make me have a reaction to it. And again, those are going to be type 2 hypersensitivities. Myasthenia gravis, thyroiditis, transplant rejections, those are additional examples of a type 2 hypersensitivity reaction. In type 3, you have complexes complexes of antigen antibody clumps that go and plug up blood vessels that cause problems. So if you ever have strep throat, for example, you're supposed to take all of your antibiotics. The reason is if you have any leftover strep in your body gets to form these, antibodies, and then the antibodies and the antigens just kind of stick together, and they go and they plug up blood vessels. So that's what happens in rheumatic heart fever. Y'all have heard of that? Rheumatic heart disease, rheumatic fever. There's glomerular nephritis is very common. Children who have had some kind of upper respiratory tract infection, they get put on antibiotics. They may or may not take them all. And then a few weeks later, the child gets brought into a healthcare provider because their urine's looking brown and they're not making much urine, and the parent or the caregiver's getting worried about them. And it's because those antigen antibody complexes have gone and deposited in the vasculature of the kidneys. And so then you quit making urine like you should. So that's a type 3. And then type 4 is the only one that's not caused by an antibody, but it's cell-mediated, so it's a delayed response, and it's going to involve your T cells instead of your B cells because it doesn't have anything to do with your humoral immune system. And then there are some examples here for you. That's what your TB skin test is. So here's a little mnemonic if it helps you remember the cause and what's going on with your different hypersensitivity reactions. And then when we have autoimmune diseases happen because for some reason or other our body fails to recognize that these parts belong in our body. So you could have complete failure, you could have partial failure. There are some genetic predispositions to developing those, and then certainly are things in the environment that can cause your body to stop responding the way it should. So if you have an autoimmune disease, you're going to present to a healthcare provider with some kind of signs and symptoms. You know, if you are attacking your pancreas, you'll end up with signs and symptoms of diabetes. If you're attacking your thyroid, you're going to have thyroid-related disorders. So a person is going to present, and they're going to have some constellation of signs and symptoms, and there will probably be a panel drawn to see which antibodies are acting up or which ones are overreacting, and that's how you get diagnosed, by looking at what antibodies you have in your blood to determine that, what's the cause of the cause of the problem. So to treat a person who has an autoimmune disorder, you can completely immunosuppress them, and that's never good because if you're immunosuppressed, then you don't fight off infection and that kind of thing. So that doesn't typically have a good outcome. They can do a plasma exchange, which means they take your blood out and they wash it and they try and get all the antibodies off of your blood, and then they put it back in. So if they can get the antibodies out, then you're not going to have the attacking of cells. And then there are cytokines that are used as medicines. Just a little bit on this transplant immunopathology. When a person gets an organ, they try to match as many antigens that are on your blood as possible. So clearly the ABO business and the RH factor is really easy to see, and it's pretty easy to match. There are like a zillion other kinds of antigens on your blood that you could have a reaction to. So even if you got, I'm A positive, I got A positive blood, I could still have a blood transfusion reaction for some other antigens that we don't really, that we're not studying about. So if you have an organ transplant, you can have a host versus graft reaction, which means I got John's kidney, and my body recognizes right away that that I want John, so I'm going to start breaking it down. If it's a really bad mismatch, like it is the blood cells types don't match, you're going to have a hyperacute reaction where you're going to probably die on the operating table. Those don't happen very much anymore, right? Because we're so sophisticated, we know how to do better matches. But it's an immediate type 1 hypersensitivity reaction, and you're just going to die probably because they're probably not going to, so when you have an organ transplant, they clamp above and below, and they get the organ all sewn in before they ever perfuse it. So it's going to take a minute to get an organ back out, a heart or a kidney or whatever back out. So if you have a hyperacute reaction, you may not survive. Then acute means it's going to happen within the first few weeks to months of having received the organ, whatever the organ is. And regardless of whether you have an acute or a hyperacute, people, once they have an organ transplant, unless it is from a 100% identical twin match, chronically are trying to get rid of that organ. So, people always feel like an organ transplant is better than not getting an organ, but your body is going to forever try to break down that organ. So individuals who do get organ transplants are going to be treated with immunosuppression for their whole life. And again, it's better, if you need a liver, it's better to have a liver than not, but you're going to be taking immunosuppressant medicines that are going to predispose you to having infections and getting bizarre cancers that people who, are not immunosuppressed don't get. And if you have a host versus graft, meaning the person attacks the organ, those signs and symptoms are going to be isolated to the organ that got transplanted to you. So if it's a kidney, you might have things like poor urine, decreased urine output, dark urine. You might start swelling up because your kidneys can't filter out the water. And then the other kind of reaction you can have is graft versus host. And what graft versus host means is that the organ that got put into your body is now trying to kill your body. That's what happened with my friend I told you all about that had ALL and got a bone marrow transplant. Her sister cells then attacked her, all the cells in her body, and that's how she died. So again, they can happen, right away. It can happen right away, or it can be a long chronic process. And if it's graft versus host, the signs and symptoms are going to be more widespread, right? Because it's not just trying to break down my kidney, it's trying to break down my bones, it's trying to break down my heart, it's trying to break down my gallbladder, it's trying to get rid of, trying to kill everything. Immunodeficiency disorders happen when you can't make enough antibodies. So if you have a deficiency of just one antibody, you're going to have less signs and symptoms. If you have disease or lacking of multiple antibodies, you're going to have a more pronounced problem. And then the problems are going to be specific to that antibody. So if a person is deficient in IgA, that might be the person who has like lots of urinary tract infections or lots of respiratory tract infections because they're so tied into secretions. So you can also not have any antibodies at all, which is called agammaglobulinemia. And so then you're going to have lots of problems. If you don't have any gamma globulins at all, you're going to be predisposed to having infections, right? But at least you still have your the rest of your cell-mediated response, your T cells and your white blood cells, so it doesn't necessarily, kill you. You can have cell-mediated problems, or you can have, so the first one we talked about were humoral, that if they were immunoglobulin related, or they can be problems with your T cells or the formation of your white blood cells and that kind of thing. And so then you're likely to have lots of cancers and lots of infections. Or unfortunately, you can have failure of both of your cell-mediated and your humoral, and that's that combined immunodeficiency, severe combined immunodeficiency disorder. That's the bubble boy concept that you've probably seen on TV. So we're going to talk about HIV, and then we're going to take a break, and then we'll come back and finish up with infection. The infection part is pretty short and sweet, so we just got to get through this HIV business. So y'all know what HIV is, right? You know how it's transmitted. There's a couple of strains of HIV. There's HIV-1, which is what we have here, and then there's an HIV-2 that is more localized in parts of Africa that's actually not really lethal, and it is a little bit protective from malaria. But HIV-1 is the one that we have in where we live the most. It's a retrovirus, and what it means to be a retrovirus is that the virus works its way into your DNA, and then your cells start making more virus. If a virus is not a retrovirus, we keep talking about COVID, well, let's talk about hepatitis. It's not a retrovirus, so if you get hepatitis B in your body, that virus is going to replicate itself and it's going to keep multiplying, but that's it. If you get the HIV in your virus in your body, that virus is going to keep replicating as well, but your cells are going to start generating it too. And so that can make it very lethal. It's not as lethal as it used to be. And so what happens in HIV is that it attacks those T4 cells. So as the HIV virus enters a T cell, it kills the T cell, the T4s. So do y'all remember what the T4 does? It's the helper, it's the director of the immune response. So if you take out the director of the immune response, how good of an immune response do you think you're going to get? Yep, you're not. And so it doesn't have to attack your whole, the virus doesn't attack your whole immune cell, your whole immune system. It's just the T cells. But those T cells, they're the key player.
Where are the T8 cells?
Where are they?
Yeah, like whatever this is going on, they don't stay with them.
They're still there, but T cells, T8s know what to do because the T4s tell them. And the T4s tell the white blood cells what to do, and the T cells tell the bone marrow which antibodies to make. And so you just don't have anybody there organizing. And so the response is going to be real haphazard, if at all. So yeah, all of these cells are either in the blood or they're in the bone marrow getting ready to be released into the blood. So how do we go about measuring HIV? We want the T4 count to be high, and we want the viral load to be low. Once the T4, CD4, it's the same thing, remember, once it gets below 200, that's when patients are going to start having all those opportunistic infections. And I got a whole bunch of slides that come up that show you what those opportunistic infections can be, and the cancers that people who are not immunocompromised don't get that often. Folks who have transplants who take lifelong immunosuppression sometimes will develop some of these same infections and cancers that patients who have HIV, because the same thing is happening, you're suppressing the immune system, you're keeping the immune system from working. If we want to know how a person's doing with the therapy that we're giving, we'll draw blood, and we're going to hope they have a low viral load, a low CD4 count or a low T4, and a high T4 and a low viral load, a low number of viruses in the blood. So the higher your T4 and the lower your viral load, the better health you're in. If you get to where your viral load is super high and your T4 count is very low, it means you got lots of virus in there and you don't have many directors of the immune response. And then that's when you start getting really sick and you get these, again, those opportunistic infections that typically will kill a person who has HIV. Y'all know the high-risk groups, right? That's transmission of blood and body fluids. So any way you can think of that a person has frequent contact with someone else's blood and body fluids, it's going to put them at higher risk. We've gotten really good with our blood supply. when HIV was first started becoming prevalent here, you know, we didn't know how to test for it, so patients who got lots of blood transfusions were more likely to develop HIV, but now we test the blood and it's a pure system, so there's not much, if any, transmission through the blood, through getting blood. So when HIV occurs, it occurs in phases, and the first one is that primary infection phase. So the person has exposure, however it is they get exposed, and they might not have a single sign or symptom, or they might just kind of feel a little bit not good, a little tired, a little muscle aching, might have a swollen lymph node. They don't have anything that's really, you know, like telltale that they have developed HIV. Plus, the exposure could have happened a month ago now, or you know, several weeks ago. So you may have even forgotten about the activity or the event that caused you to get somebody else's blood or body fluids on or in you. And so, while that's going on, while you're having these mild signs or symptoms that you probably don't think much, look, if I get tired, I don't run to see a doctor. If I get a little muscle achy, maybe I get a little bit of diarrhea, my throat hurts, I'm not, you know what I mean? It's like most people say, let me just wait a few days and see if this gets better. So a lot of folks never go and get checked out or find out that they have it early on. Plus, they haven't seroconverted by then, and so they're probably not going to be able to tell it from a blood test anyway. And so that's going to go on for a little bit, and then you're going to, the disease becomes what's called the latent phase. And during this latent phase, that virus is replicating and it's attacking more and more T4 cells, destroying more T4 cells. Your body's making more virus, the virus is doing its own thing, making more, and every time there's more virus made, it's going to go and attack a T cell, a T4 cell. And that T4 cell is going to die, and it's going to even release the bacteria back into the bloodstream, so it just really knocks out your immune system. So that latency phase can last a long, long time, or it can last a shorter period of time. I suspect, based on how strong your immune system was to begin with, is going to determine a lot of how long it takes a person to start having overt signs and symptoms. So this whole time, again, your T4 count's going down and your viral load's going up. And then it advances to overt disease, which luckily we have a lot better medicine than we used to have, and not as many people in our part of the world advance to overt disease as they used to. But here you're going to have, again, that T4 count that drops down less than 400, and you're going to start having some of what we call AIDS-defining illnesses. And those are those opportunistic infections. And it's things like massive weight loss, diarrhea. They get encephalopathy, start getting confusion. So if they have a CD4 count of less than 200 and they have an AIDS-defining illness, then they're said to have converted to having AIDS. They're not just any longer just a carrier of HIV, they actually have full-blown AIDS. And the next set of slides, y'all, you probably could just kind of just rush through them real quick. These are a bunch of the opportunistic infections that folks do get, and you're going to see, like you probably all had strep, probably not strep pneumonia though. None of you have probably had cryptococcus. I doubt many of you have had TB. You haven't had Legionella. You haven't had that pneumocystis erythema either. But I guess the thing to know is that, I mean, they can have these opportunistic infections, but they can also have the same infections that you get, strep throat, that kind of thing. So when you see a person and they start developing lots of infections, you have to question the virility of their immune system. So folks will get nervous system infections that have AIDS. They call it AIDS dementia, where they become they get repeated infections from cytomegalovirus inclusion virus or toxoplasmosis, and it destroys their neurological system to the point that they become, incoherent and confused and that kind of thing. These are some of the cancers that folks get that occur commonly in folks who are immunocompromised, especially HIV patients. Cervical cancer, the reason that that's on this slide is that because a person who has an immunodeficiency, their natural killer cells aren't going to delay the development of that cancer. They have to have the routine screenings for cancers much more quickly. Like most females have a pap smear, you're supposed to have one every year, they would need to do it like every 6 months. You know, colonoscopies, you wouldn't wait until you're 50 to start having, you probably start having them when you're 30. So you do all those screening procedures earlier because they can develop so much more quickly. That's Kaposi sarcoma, it's a skin cancer. We already mentioned before diarrhea, maybe fever, I don't know if we mentioned fever or not. Lipodystrophies, that means that the distribution of fat is abnormal. So, like for example, on my arm, a person might have a big old nodule that looks like the size of a golf ball that's up under the skin, and that's a chunk of fat. That's what a lipodystrophy is. They get these lumps and lesions of fat. You know, but most of the time fat's kind of spread out right. It's shaped, it's just kind of a slab, instead of having these knots and nodules in it. And then to diagnose it, there are several tests that you can do. I don't even know if it's that important to know, but there are multiple tests. Now, there's a rapid HIV screening test that can be done in the hospital. So if you get stuck by, or you get someone's blood and body fluid on you again, the process is you go to the patient, you say, hey, look, you know, I stuck myself with the needle I just gave you a shot with, or whatever, you vomited on me and it got in my eye. And so then there, you have to ask the patient permission to draw their blood and check. And so you're going to be checking for things like hepatitis B and hepatitis C and HIV. So there is one now that you get the test results back within just a couple of hours. It's a precursory kind of thing, but it gives you a good idea that they are negative or they are positive. If they're positive, you're going to take some of this antiretroviral therapy. That's what ART is. Antiretroviral therapy. If you take it early on post-exposure, you can even take it prophylactically. It helps cut down on the transmission of HIV. But for a person who does have HIV, if they can afford and have access to their medicines, the life expectancy for a person with HIV has gotten much, much better. So I had my first child in 1982, and I can remember I worked in a burn center, and we had that first HIV patient that had come into our hospital, and so I don't remember how far along I was, but I was, you know, good and showing. I worked in the burn center, and it's like they rolled up from the ER with this patient who had HIV, and they put tape on the floor and told me I couldn't cross that side of the line. It's like, you know, everybody was scared. You didn't know how you got it. It was a critical care unit. There's ventilators and stuff blowing all around and that kind of thing. So it used to be like that, or if, you know, HIPAA was enacted then, but I guess people, you know, didn't pay attention. And like if there was an HIV patient in the hospital, it's like, oh yeah, the patient in 608, you know, he's got HIV or whatever. And so people, it was like a novelty and something you kind of wanted to see, but you were afraid to go see. Now, you know, the person sitting right next to you may have HIV and you would never know. So it's very common. It's a common disease, and you say you're supposed to treat everyone like they have HIV. That's what universal precautions came from. Have y'all done that yet in skills? It's from that idea to protect yourself from blood and body fluids. So you can take this antiretroviral therapy, and they're going to track, again, your T4 count and your viral load, and hope that the T4 is high and the viral load is low. If you know you're going to be engaging in risky behavior, or you know you're going to have to get a massive blood transfusion, you could take these antiretrovirals before, and it would help cut down the likelihood that you would develop HIV. Some things to keep in mind: it does cross the placenta, it does cross in the breast milk, so a pregnant mother can transfer HIV to an unborn baby, to the baby after it's born if they're using if it's breast milk. If the baby is not positive, though, within about the first 6 months of life, they're not going to develop HIV. If they do test positive in the first 6 months of life, they're going to be very sick little children very quickly. They have a very poor outcome, babies who are HIV positive. Before a mother gives birth, if they have HIV, they will get big doses of those antiretrovirals to try and suppress, to decrease their viral load, so that it's less likely that the virus can be transmitted to the baby during that birthing process. And kids with AIDS, they have failure to thrive, which means they just don't develop. They are small, they don't eat well, their neurological systems, all their systems, that, you know, they don't grow and developmentally or physically like a child should. They get lots of central nervous system issues. They start having those pneumonias and those opportunistic infections really early in life, and they just don't do very well. Okay. So y'all give me 5 minutes to go get something to water, and we'll come back. Infection will take us about 30 minutes to finish up. You know, a question that people miss a lot, but is what immunocompetence is. Immunocompetence means that your immune system works like it ought to, right? People always tend to think of that as being immunocompromised. The other things that are up here probably are self-explanatory. Nosocomial and healthcare acquired, those words seem to come and go in popularity in healthcare. So up until about 5 years ago, that word nosocomial was never mentioned. Nosocomial means caused by man. And so it used to be if you got an infection or you had something go wrong while it was in hospital, it was called a nosocomial. And then that just became a bad word, and it was out of all the textbooks, and nobody ever taught anything about it. You still heard people in the hospital say it a little bit because they've been working in the hospital for years. And everything went to healthcare acquired, but I'm seeing that nosocomial is coming back into some of the textbooks, so just be aware that it's a word that comes and goes in popularity, but it does mean that it's something that happened to you as a result of getting health care. So y'all, for an infection, all living things seek to live and reproduce, and so anything, whether it's a rickettsial pathogen, or it's a bacteria, or it's a virus, it's going to try to get what it needs from the host, which is you. So it's going to try to get everything that it needs to stay alive and to reproduce. Now, what is the rest of this business is the different kinds of organisms that can cause infection, and what are the characteristics of that organism. What are some examples, maybe, and how virulent is it? So virulent means the likelihood that it can cause disease, or the severity of the disease that it causes. So these next, however many slides are left here, are about different kinds of organisms and their ability to produce disease and our ability to take care of them. So you kind of just want to make a list and know that, like, what is the organism? What does it do? How does it survive, and can we kill it or not? How do we take care of it if a patient gets this? So the first one, the most virulent, the one that's most likely to cause death and not be able to be treated, is a prion, and so that's what's on this first slide. And a prion's not a complete organism, it's just a protein structure, and you contract these prions from contaminated, either from getting a tissue in you. So you could get it from eating the raw meat of an infected organism. You could get it if maybe some surgical equipment wasn't cleaned very well and there's tissue that's left on the surgical instruments. So this is, y'all have all heard of mad cow disease. So that's caused by a prion. The bad thing about this is that they go undetected. You don't get sick or anything until you die, and you're going to die. So it doesn't cause any kind of reaction in your immune response. Your immune system does nothing whatsoever to try and kill it. So it's the most lethal of all of these. We don't have anything we can treat it with. Viruses are, coming down the rung on the ladder, and these are organisms that don't have a cell wall, and they can have either DNA or RNA, but they don't usually have both. They have to be inside a living cell to reproduce. We do have some antimicrobials, a few, but not as many as we do for bacteria. So it's like those antiretroviral medicines for HIV, they're helpful, but it's not a given that the medication, the antimicrobial, is going to work like it is with the bacteria. And viruses, once they are in your body, sometimes they stay there forever. Like we talked about Epstein-Barr virus. If any of us have Epstein-Barr virus, it's going to stay there probably forever. And so there are periods of time when the virus can cause you lots of problems, and periods of time where there's no problem going on whatsoever. Bacteria is getting a little bit further down the ladder still, and certainly we have more effective antibiotics to treat bacteria. Bacteria typically have a cell wall, and they can reproduce. They can reproduce either sexually or asexually. They can require oxygen or not require oxygen. Bacteria oftentimes will develop a sensitivity, so that the antibiotic that is typically being used to treat MRSA, y'all have heard of MRSA, methicillin-resistant Staph aureus? It's just a Staph aureus strain that has developed resistance to penicillin. So what that means is that the antibiotic that has been used historically to take care of the organism doesn't work anymore. You'll see throughout your healthcare career that there are going to be organisms that appear or that transform and become antibiotic resistant. And that comes from the overuse of antibiotics or people not using the antibiotics appropriately. So you go home and you have a staph infection, and you got a sore throat or a strep infection, and so you get placed on some antibiotics and you feel better. And after 3 or 4 or 5 days, you think, I'm not gonna keep taking this antibiotic. I feel better, and that way I'll save this extra antibiotic. And the next time I get sick or someone in my family gets sick, we don't have to go to the doctor. We can just use that antibiotic. And so that's the kind of behavior that promotes the development of these resistant strains. Also, if you take an antibiotic every time you have a runny nose, it's gonna, provide more exposure to more bacteria to the antibiotic that then allows for the, again, the development of these superbugs. So it's real important that we don't abuse and misuse antibiotics. If they're named by the genus, which is typically a capital letter, and followed by the species, which is a small letter, and they're written in italics. And then fungi, they are organisms that feed on dead or dying tissue. So mushrooms, yeast, they need to get what they need to survive from this dead or dying tissue. They're called mycoses. Parasites are little bugs of some sort. Could be a worm, could be a tick, again, that injects some kind of toxin into you. They're easy to take care of. Parasites are pretty easy to kill. Chlamydia is considered parasitic. It's the most common sexually transmitted disease in our part of the world, and they are transmitted from person to person, where rickettsial infections, which we're going to talk about next, go from a vector, a bug, to a person. Chlamydia is person to person. And then rickettsia, again, this is a organism that's considered parasitic, and it's carried in a bug. Usually ticks are the most common vector for these rickettsial viruses to live in, and so they live in their organism, probably a tick, and they don't make the tick sick, but when they get into humans, they make the humans sick. A couple of things that are important to know about ticks are, well, number one, stay away from them. Number two, they have to be on you for many hours, 12 to 24 hours before they make you sick. So you want to be careful about taking the tick off, because can you see that tick there that's full of blood? You can see if you grab that part of the tick, you're likely to squish whatever's inside that tick into you. So you don't want to do that. You want to put some alcohol on it and get the tick to withdraw itself, or get some forceps and go between the tick and your skin to get it off. These rickettsial infections, they can cause neurological issues down the road, but we're going to talk about that when we talk about skin infections, skin conditions, much later in the semester. And so those are the organisms that you need to be familiar with. What are they? How we take care of them. And then just this is probably a repeat. Have you already done the infection lecture and skills yet? So this is a repeat, right? Y'all know what all that is? Okay. You know about these different periods of an infection? Incubation, prodromal, acute, convalescence, and resolution. Okay? And then, it's nice though, isn't it? Because it's like we're coming at y'all from so many different classes, and honestly, about halfway through the semester, it seems like things line up a little bit better than they do right now. Because in all your classes, the faculty are teaching the things they think are the most important, or the things that apply across the board, and it's not the same in pharm as it is. Well, you're not taking pharmacology. And skills versus patho versus health assessment, but they will kind of all come together at the end. And then what can make things, infections worse? Well, depending on where it is, right, an infection in my heart is clearly gonna have a worse outcome than an infection in my fingernails. How strong is the bacteria or the virus or the parasite? Just, you know, how sick can they make you? How well do they stick on you? How much do they reproduce? You know, can they get away from the antibiotics or the antimicrobials we're trying to use? Those things can determine how severe your infection is. How immunocompetent is the person that has the infection? If you remember when COVID first started, the pecking order for vaccinated people were, okay, those, I think it was started out, those over 75 were the first ones to get vaccinated. Over 75 or with a chronic condition, you could go ahead and get vaccinated early on because they have weakened immune systems anyway, and they're going to have the highest likelihood of dying from an infection. Versus, you know, you all were the last ones, right? You were late high school, I guess, or early college, and y'all are considered the most healthy people out there, and so that's when the vaccines made it to you all last. So if you think about who's most likely to have a poor outcome from an infection, it's kind of that same order that the COVID vaccines were given out in. And the last two slides are on bioterrorism and global infectious diseases. And really what you need to be familiar with the names of these organisms. But there is, I mean, you probably in your life may never see smallpox. So, I'm not saying that it's important to go and study how to recognize smallpox and how to know what it is, and what to do and that kind of thing, but you need to stay abreast of whatever's going on in the world around you so that you know how to respond to those kinds of things. As far as, terrorist activity or for global infections. And the last slide is on global infections, and some of these you probably are familiar with. Everybody knows what COVID is. West Nile virus is, it flares up about this time of year, every year, and it's a mosquito-borne illness that can cause death. SARS is actually a coronavirus, but it's been around much longer than the COVID-19 strain. Do y'all remember hearing about Ebola? So there was, I think it was in Texas, there was a nurse in Texas that I think died with Ebola. There was a person who had come in maybe from, I don't know, Ebola was probably over in the African continent. He traveled and he came to the hospital, and Texas didn't feel well. They sent him home, and he came back and he died with Ebola. And so then all these hospitals all over the world, all over the United States, set up these tents outside so they could isolate Ebola outside. And then Zika, do y'all remember Zika? Zika was not very long ago either. If you were infected by Zika when you were pregnant, it caused neurological problems in your babies. So listen, y'all have class this afternoon, right? Dr. Swansea asked me to be sure to remind y'all not to forget about 311 after class. And we'll get your grades up sometime this afternoon. If after you see your exam, if you want to meet with either Dr. Swansea or myself, I think